For decades, the clock for acute ischemic stroke management started at the emergency department doors. The 2026 AHA and ASA guidelines shift that starting line. The true clinical baseline for rapid reperfusion now begins inside the 911 dispatch center. Under the new operational mandates, EMS dispatchers must use validated telephone stroke assessment tools for all caller triage. This initial phone call functions as the first diagnostic node in the patient's clinical journey. The clinical objective of this early screening is to identify suspected stroke symptoms immediately, compressing on-scene time and prioritizing specialized routing before the ambulance even leaves the station. This pre-arrival strategy is reinforced by a Class 1 recommendation for the use of telemedicine in the field. First responders are now expected to complement their physical assessments with live remote evaluations when feasible. Integrating teleradiology and telestroke systems directly into the pre-hospital environment accelerates the decision-making process for intravenous thrombolysis. The patient is evaluated and contraindications are ruled out while they are still in transit. Relying on hospital-side speed to manage stroke care is no longer sufficient for optimal outcomes. Maximizing a patient's chance of intact survival requires a fully integrated pre-hospital data pipeline operating at peak efficiency. Once a stroke is identified in the field, EMS faces a critical routing dilemma: drop the patient at the nearest local hospital or bypass it for a distant, specialized stroke center. The instinct to transport a patient directly to a comprehensive thrombectomy-capable stroke center, or TSC, can be counterproductive. If that transport requires extensive travel time, it may actively degrade the patient's prognosis. This geographic routing flowchart outlines the exact parameters. Bypassing a well-coordinated local hospital that is proficient in thrombolysis for a TSC 45 to 60 minutes away yields a Class 3 no-benefit outcome. The transport delay negates the advantage of the specialized center. To bridge the gap between geographic distance and rapid intervention, the guidelines explicitly mandate the deployment of mobile stroke units where regional infrastructure allows. For patients with suspected acute ischemic stroke, deploying a mobile stroke unit over conventional EMS is now a strict Class 1 recommendation. These specialized units ensure the fastest achievable onset to treatment time, providing immediate thrombolytic administration and driving direct, measurable improvements in long-term functional recovery. The ceiling of a patient's neurological recovery is largely dictated by decisions made before they ever reach an admitting desk. Advanced field capabilities and strict geographical routing protocols determine that trajectory. The moment the ambulance bay doors open, the pre-hospital phase ends, and a rigid countdown takes control of the patient's care. The Class 1 standard for hospital systems dictates that emergent brain imaging must be completed as rapidly as possible, targeting an absolute maximum window of 25 minutes from arrival. This rapid scan serves a singular, immediate function: differentiating arterial ischemic stroke from hemorrhagic stroke, and quickly ruling out structural contraindications for thrombolysis. Alongside the imaging protocol, clinicians must establish a baseline clinical deficit, utilizing a standardized rating scale, with the NIH stroke scale mandated as the definitive tool. The NIH-SS provides a critical predictive baseline, allowing teams to gauge the risk of severe downstream complications, such as intracerebral hemorrhage, while quantifying the neurological deficit. Achieving the 25-minute imaging metric while capturing an accurate NIH-SS score is the essential prerequisite for proceeding with reperfusion therapies. For adult patients presenting within the traditional 4.5-hour window, the pharmacological decision node requires exact precision in selecting the thrombolytic agent. The 2026 standard specifies exact dosages for functional recovery. Tenecteplase must be administered at 0.25 milligrams per kilogram of body weight, or alteplase at 0.9 milligrams per kilogram. This comparison chart shows the strict dosage guardrails. Administering tenecteplase at the higher 0.4 milligrams per kilogram dose is explicitly flagged as a Class 3 recommendation. It provides zero additional clinical benefit. Practitioners must also avoid treating mild, non-disabling deficits, such as isolated sensory syndromes, with aggressive intervention. Delivering intravenous thrombolysis for these minor deficits shows no superiority in improving patient outcomes when compared directly to standard double antiplatelet treatment. The 2026 guidelines introduce a major shift in the treatment timeline, extending the IVT window from 4.5 up to 9 hours for late presentations. This extended window operates under one strict, non-negotiable parameter. Automated perfusion imaging must actively confirm the presence of salvageable ischemic penumbra. Physiology-driven imaging thresholds have replaced fixed temporal cutoffs as the primary determinant for treatment eligibility in these extended cases. Once reperfusion is achieved and the patient moves to the ICU, the clinical priority shifts heavily toward restraint. There is a strong medical instinct to aggressively force a post-operative patient's physiology back to normal baselines. In acute stroke care, this instinct can be hazardous. Following intravenous thrombolysis, intensive systolic blood pressure reduction to a target under 140 millimeters of mercury is a Class 3 rule. It yields no functional improvement compared to standard targets under 180. For patients who have undergone endovascular thrombectomy, the guidance against aggressive blood pressure management escalates from a lack of benefit to an active threat. This applies specifically to patients with anterior circulation large vessel occlusions who have been successfully recanalized. This gauge visualization illustrates the critical boundary. Targeting a systolic blood pressure below 140 millimeters of mercury in the first 72 hours for these specific EVT patients triggers an explicit Class 3 harm classification. Intensive blood pressure reduction in this specific window chokes off the requisite flow, actively endangering the newly salvaged brain tissue. In the delicate post-EVT environment, aggressive hemodynamic normalization is actively destructive. The final physiological metric demanding disciplined management is blood glucose. There is an uncontested requirement to immediately treat hypoglycemia, defined as blood glucose below 60 milligrams per deciliter, to prevent severe acute neurological complications. However, managing high blood sugar requires pulling back. The clinical assumption that strict normal glycemia should be enforced using intensive IV insulin protocols has been dispelled. Driving a hospitalized patient's blood glucose levels into the strict 80 to 130 range using IV insulin offers zero improvement into 3-month functional outcomes. When we pull back and view the 2026 AHA/ASA guidelines in totality, the pathway rests on 3 core pillars. First, reperfusion success relies on pre-hospital systemic speed. It requires optimized 911 routing and the mobilization of field-level stroke units. Second, precision perfusion imaging now overrides rigid time clocks, expanding the boundaries of thrombolytic eligibility based on salvageable tissue. Third, post-operative success requires profound clinical restraint. Physiological overcorrection in the ICU actively undermines the interventions achieved in the emergency department. Mastering modern acute stroke care demands deep operational efficiency, but more importantly, it requires rigorous discipline in knowing exactly what not to do.